In our final video, we will discuss the treatment and prevention of community-acquired pneumonia. To help decide on treatment, the clinical classification of pneumonia can be broken down into two groups: typical, usually infections due to conventional bacteria, and atypical, sometimes called walking pneumonia, caused by viruses and intercellular bacteria, Mycoplasma, Chlamydia, and Legionella. Typical pneumonia is characterized by an acute onset, a productive cough, moderate to severe illness, and chest ache showing a lobar or bronchopneumonia pattern. Atypical pneumonia is usually subacute in onset, has a non-productive cough, illness severity is mild to moderate, and chest x-ray shows an interstitial pattern. This characterization helps to choose empiric antibiotics and for deciding on the need for hospitalization. Patients with typical pneumonia have a much higher likelihood of being hospitalized. And for hospitalized patients, I wanted to emphasize the importance of drawing two blood cultures before antibiotics are begun. Blood cultures are strongly recommended for patients who complain of rigors and for those who have severe illness, because these cultures are positive in 1 to 16% of CAP cases. Because bacteria double every 60 minutes, time is of the essence, and antibiotics should be initiated within 4 hours. Delays in therapy are known to increase mortality. The IDSA treatment guidelines recommend for hospitalized patients an intravenous third-generation cephalosporin, usually ceftriaxone. The 2019 IDSA guidelines now recommend combining ceftriaxone with a macrolide, or azithromycin or clarithromycin, or to use a fluoroquinolone, which will cover both conventional bacteria and atypical bacteria. For patients suitable for outpatient management, a macrolide is recommended, and the most commonly prescribed macrolide is azithromycin. The duration of therapy depends on the patient's response. The trend is toward shorter antibiotic courses. The minimum treatment for community-acquired pneumonia is 5 days, and most practitioners continue for 7 days. In patients diagnosed with influenza virus by PCR or antigen test, Tamiflu, oseltamivir, 75 milligrams daily, is recommended for 5 days, and has been shown to reduce the severity of influenza pneumonia. Recent meta-analysis reveals that corticosteroids are helpful in patients with severe community-acquired pneumonia, improving oxygen exchange by reducing inflammation, and corticosteroid administration has been associated with a reduction in the need for mechanical ventilation from 29.5% to 18% and reduced mortality from 11.9% to 6.2%. In patients with elevated BUN and evidence of dehydration, cautious intravenous fluid administration can be considered. However, fluid replacement should be conservative because the risk of fluid accumulation in the inflamed alveoli has the potential to worsen oxygen exchange. Finally, for all patients with hypoxia, nasal oxygen should be administered to maintain O2 saturations above 90%. This sketch note summarizes the recommended treatment for CAP. Antibiotics within 4 hours after blood cultures are drawn. Hospitalized patients should receive ceftriaxone and azithromycin. Outpatients, azithromycin. Cautious IV fluids for dehydration. Corticosteroids for severely ill patients. And oxygen supplementation to maintain O2 saturations above 90%. What is the outcome of CAP? As discussed in video 1, mortality can be high, ranging from 2 to 30%. And mortality is higher in patients 65 years of age or older, in patients with neoplastic disease, liver disease, congestive heart failure, those who have suffered a cerebrovascular accident, or have significant renal dysfunction. Given the potential for hospitalization and death, prevention is a very important strategy. We have learned from the SARS-CoV-2 pandemic the importance of avoiding small public spaces. Gatherings should be held in large, well-ventilated spaces with exchange rates of 6 to 12 volumes per hour. When in public during peak activity of these diseases, KN95 masks can reduce spread. And vaccination not only can prevent disease, but also reduce disease severity. Influenza vaccine should be given annually to the elderly, pregnant women, the chronically ill, the very young, and school-aged children. Pneumococcal vaccines are very safe and efficacious, and there are two that are now given, the 23-valent and the new conjugated 21-valent pneumococcal vaccine. They should be given to those who are 65 years or older, those with chronic disease, asplenia, immunocompromised, and to alcoholics. SARS-CoV-2 and Haemophilus influenza Hib should be given regularly as recommended. Another significant preventative measure for those who are smokers is smoking cessation. Now let's return to our 66-year-old male patient. What were the results of his diagnostic workup? Here is his chest x-ray, laboratory findings, white blood cell count 8,000 with 60% PMNs. This is within normal limits. Procalcitonin 0.20, CRP 3 within normal limits. Arterial blood gas PO2 60, PCO2 35, pH 7.35, indicating he had hypoxia. Sputum gram stain showed a few PMNs and monocytes and no organisms. Here is his revised illness script with all the diagnostic results. A 66-year-old man presents with subacute onset of shortness of breath, dyspnea, at rest, accompanied by fever, myalgias, headache, and a non-productive cough. He denies chest pain. He has marked tachypnea, respiratory rate 30, sinus tachycardia, low oxygen saturation, rouse at both posterior lower lung fields. Epidemiology, it is a late fall, no known 6 contacts, no animal or environmental exposures. He did not receive the influenza or pneumococcal vaccines. Past medical history, he is a 40-pack year smoker and may have COPD. His chest x-ray shows diffuse interstitial infiltrates. His white blood cell count is 8,000 with 60% PMNs. Procalcitonin is 0.20, CRP is 3, arterial blood gas PO2 60, PCO2 35, pH 7.35 on room air. Sputum gram stain showed a few PMNs and monocytes and no organisms. What is the most likely cause of his pneumonia? Pneumococcal, chlamydia, mycoplasma, influenza, Staph aureus, or Legionella. We will pick a diagnosis during our interactive class session. To summarize our 4th video, we learned how to differentiate typical from atypical pneumonia. Remember to draw blood cultures before antibiotic administration in severely ill pneumonia patients. Begin antibiotics within 4 hours. For hospitalized patients, ceftriaxone and azithromycin. For outpatient, azithromycin. Levofloxacin can be used as an alternative. To prevent contracting this disease, avoid small, closed public spaces, wear KN95 masks, and make sure you are up to date on all your vaccines. Let me offer a final summary of the topic of community-acquired pneumonia. This is one of the most common infections in the elderly, nearly 1 per 100. We reviewed the symptoms and signs of community-acquired pneumonia, emphasizing the diagnosis of typical versus atypical pneumonia. We emphasized that chest x-ray should be performed in all patients suspected of pneumonia. Sputum gram stain is very useful, and there is now a trend toward using a respiratory PCR to make rapid diagnosis. Antibiotics should be started within 4 hours, and I emphasize the importance of preventative measures. Vaccination for influenza and strep pneumoniae, SARS-CoV-2, face masks, avoiding closed public spaces, and discontinuing smoking. Thank you.